started with you, Rishi. You've written a book recently about the divide between care delivery and the life of the patient outside of the facility, the doctor's office or the hospital or whatever it might be. Can you tell us more about this and what is meant by this terminology around patient-centered care?
Absolutely. So the book that you referred to is called The Upstream Doctors, published by TED Books recently. And in the book, I talk about the role of not just the partialists, who are the specialists that take care, as Paul Grundy from IBM says, of your left eye, your right kidney, the specialist who's vitally necessary in our healthcare system. Not just about the comprehensivist, who is now the primary care clinician who's in charge of your continuity and your coordination of care as part of the clinical team, but also the upstreamist, a term that I use to describe a segment of the healthcare workforce that currently exists. It's not often talked about, but these are the healthcare workers, sometimes doctors, sometimes nurses, who are charged with the responsibility in their healthcare settings of aligning the care delivery process with the social determinants of health in the community. Plain English, where people live, work, eat, sleep, and play. And so I'll speak about what this means for workforce and data and tools, those 3 points, but the way to really drive this home is to just tell a story. It's about 4:30 right now. I'm just going to go into story mode really briefly. About a year and a half ago at a clinic in South Central Los Angeles where I practiced for a while, a woman came in, 33 years old, Veronica. She came in with a chronic headache, had these episodes of the headache for 3 years, and each episode was getting progressively worse. In the 3 weeks prior to coming into our clinic, she had gone to 3 different emergency rooms, had received in some 2 CAT scans of her head, 1 spinal tap, about a dozen blood tests, and was told at the end of each episode in the emergency room that everything is quote-unquote normal. Here's some Vicodin, and go follow up with your primary care physician. And come back, of course, if the symptoms persist or worsen. Sounds pretty familiar. She, true to the recommendations, came back, and again 3 times to the emergency room, and finally stumbled into our community, our FQHC, Federally Qualified Health Center. That story that I just told you is far too common, and in fact it is the de facto standard of care, I think. Individually, each provider was providing good care, diagnoses, treatments, et cetera, but was collectively, I think we clearly weren't getting the outcomes we wanted, increased costs, unnecessary utilization, and when I saw her, the most important thing is, of course, that Veronica was still sick. And now she was not just sick, but she was exasperated. So I turned the doorknob into the room and saw her. She's 6'1", formidable presence, and she had her head in her hands, her elbows on her knees, and was now facing not just persistent pain, but a $1,200 bill from the first visit to the ER alone on a monthly budget of $850. The better standard of care that I think exists out there among various clinics, including FQHCs, but even some public and private systems alike, is a model that actually that we implemented there. My medical assistant, before I saw her, actually asked questions about her chief complaint, headache, her vital signs, stable. She also asked questions from the American Housing Survey because in South Central, the community told us that slum housing, substandard housing is a major driver of disease, and so we followed the mandate given to us by our community and started asking questions from the American Housing Survey, 7 questions that we boiled down with input from the community. And when I saw the piece of paper, this is pre-EMR implementation, when I saw the piece of paper, it said headache, vital signs stable, and 3 out of the 7 questions were positive: mold, roaches, water leaks in her home. She was the 17th patient out of my 26-patient day. I turned the doorknob, and the first thing I saw as she lifted her head was this crease on the bridge of her nose, which in medicine is the allergic salute. Chronic allergies lead to chronically rubbing your nose. It creases the bridge of the nose, and you end up with this sign that's called the allergic salute, familiar to many practitioners in this room. That crease on the bridge of her nose, which is as plain as the nose on her face, was not picked up on. I went back through the records later on, and no doctor, no nurse had actually commented on that allergic salute, in part because I believe that they were not primed with the social data that I had. I'm not a better doctor inherently, but I was a better doctor because I worked in a better system that captured the social data. The upstreamists out there collect this data. I think the implications are pretty profound if we're thinking about the triple aim, if we're thinking about patient-centered care. we've had a lot of discussion so far about the EMR data sets, about the claims data sets that are out there, but as I mentioned to some people in the sessions, the networking sessions, what about the social data? What about Veronica's home? What about the patients in terms of where they live? And the rigor that we expect of ourselves right now to do the data analytics, to do the care delivery for patients and with our traditional biomedical model is something that we haven't brought to bear for the biosocial data, for the biosocial phenomena that is health. And when we do so, as it turns out, after interviewing a lot of people around the country, these upstreamists are part of this, this drive that I think is very much part of not just delivering better patient-centered care, but frankly, and doing so by thinking about the 5,000 hours outside of the clinic that patients, where they spend their lives. It's also our way for achieving the triple aim. And when we don't incorporate that social data, you get not only missed opportunities for prevention, but frankly, poorer care. Now think of Veronica's story, right? She kept on going in and out of care. That's just substandard. Too costly. It leads to job satisfaction issues for the providers and therefore higher attrition rates. It leads to patient dissatisfaction and lower engagement with the healthcare system. Once you start to actually incorporate social data collection, in other words, where do you live, where do you work, where do you sleep, and then have the training and support structures in the healthcare system to take that data and do something with it, then you actually get a system that makes a lot of sense. And you have providers who feel more satisfied. Our providers in a community health center and the data that we've seen across the country indicate that providers who work in these clinics that incorporate the social data as part of their care delivery process are routinely more satisfied with their jobs, stay longer at their workplace. Turns out their patients are also happier, so if you care about patient satisfaction, it works out. So I think the challenge for the workforce is, how do we recognize upstreamists? When it comes to data, how do we recognize social data that's out there and incorporate that? And when it comes to tools, in addition to the macro tools, the meso tools, and there are also micro tools at the patient level. One of the things that HealthBegins has done, the organization that we started to help provide training and tools to the upstreamists, was to actually develop a Yelp-like interface. We found that repeatedly patients were coming in with unmet social needs, and doctors went to the common use case, which is, okay, well, maybe you can talk to Leticia. She's in the clinic right now. She's our care manager, our social worker. Oh, but she's out today. Or if she's there, then here's the binder that she has with tattered pieces of paper and the outdated number for the WIC agency or the housing agency. An incredibly archaic system in a day and age when we can find a restaurant review with an app. Right. So we took resource listings that exist in the community and put that into an interface to at least address that pain point, and as importantly, use that as a point of entry for helping these clinics start to feel like they have some efficacy, to really fulfill the patient-centered vision.
So is this going beyond, is the HealthBegins protocol being replicated elsewhere?
So the first thing we did was, when I worked for about 4 years in South LA, I realized that there were a lot of these folks who are out there and these blips on the horizon. First thing we did was to create an online network when we started HealthBegins to at least connect the dots, create a learning collaborative among these would-be or current upstreamists. Many of them are people who have different job titles, like the chief information officer, the chief medical officer, the assistant chief medical officer. Some of them have these job descriptions that allow them to think about the social needs. We created that network, and that network to this day is now the very network that provides us with the content, helps us to quickly vet the innovations that are already bubbling up from that community, and then we get to think about how do we scale some of the most interesting ones up. So it's a kind of a pipeline for innovation at that intersection of the clinic and the community. Right,
right. Joan, I want to turn to you now. You focus on the context of the patient journey from a design perspective. Can you tell us how design enables or fosters, or can enable or foster patient-centered care, and how that may change the outcomes for patients?
Yeah, that's a great question. I think one of the first things we have to do is think about patient-centered care and design, take it away from an episodic kind of thinking, that interaction between you and your caregiver, and really broaden that, because it's really something that's scalable. Like, we're being asked to design brand new cities in Asia and in the Mideast that has to incorporate education, access to healthcare, energy, think about sustainability, residential, transportation, all that. So we think about it on that big scale. And also thinking about revitalizing some of our cities, like what's going on in Detroit right now. They're partnering with their health systems to revitalize their urban environment. And what happened in the city of Pittsburgh with revitalizing the waterways and the walkways around the shoreline so that it invited economic development. It was a safe place to go and exercise and really, revitalize that area. And then you think about the traditional environments for delivering healthcare, the hospitals and the clinics. And I think we have an opportunity to think about that differently, to reimagine it, and perhaps even to blow up the way that we've thought about planning for healthcare in the past. So if you think about the patient room, I mean, right now, a lot of great design going on in there, family space, light, being efficient, being able to enable the clinicians to do their job. They look like hotel rooms, a lot of them. But what if we took a different point of view in the context of what we talked about this morning and really thought about the patient room as a classroom? What about that it's the place where that transfer of information, where education is happening, that there's an engagement with the clinician versus being talked at? How would you think about that differently? How would you redesign that? And I think you would. And then the other aspect of design is it's so interesting that when we're engaged to design a new building, it's just assumed that people are going, clinicians are going to move into it and know right away how to work within that space. I'm sure you do, yeah. So one of the things that we have to think about is what we're calling the clinical workplace. And I think this is where healthcare is really behind. And we're learning from some of our other clients like Google and Amazon and a number of others of how do you enhance that workplace? Like for instance, Google designing their new headquarters, they've determined that innovation is happening with casual conversations. Google Maps, a couple other things, Gmail, that all happened from casual conversations. So their new headquarters, 1.1 million square feet, is being designed that no employee is more than a 2.5-minute walk to another employee in terms of stacking and connecting. So if we took that same sort of design parameter to healthcare in terms of multidisciplinary interaction in a clinic, ambulatory setting, or within an acute care environment, I mean, I think that could be pretty powerful.
And can you tell, you told me about some of the outcomes, that how some of these design changes have actually resulted in different kinds of results for the patients that have been involved in them. Can you help us illustrate that?
For sure. Just not far from here at Mass General, working with the clinicians there, designing a new emergency department. At the same time, they were redesigning their triage and screening program, and they came upon thinking and finding out that if a patient can see a physician within the first 10 to 15 minutes, it greatly increases throughput, gets that patient to a life-saving procedure faster versus being held up in sort of the throes of grinding your way through an ED.
Yeah.
So.
Yeah. You also told, I would encourage any of you who are interested to have a look at the website for NBBJ, because it's a very visual business that Joan is in, and we can't show you all that. We don't have the opportunity to really take you through that. But some of the images are just really, they're quite compelling. But can you tell folks about some of the tools that you've used that help change or impact the way we think about space?
Yeah, it's really interesting listening to all the conversations about data. And we're always chasing metrics so that we can learn from evidence of what's been done and what's a good way to do that. And there's now a great tool. It's called parametric design. And it actually came from computer software designing the envelopes of buildings, the enclosures. So you put in all kind of data, parametrics, metrics about how energy efficient you would want it to be, where it is in the world, the sun angles, this and that. And it would tell you, basically how you would design, how much glass, type of glass, that kind of stuff. Now we're starting to take this parametric model, and since our designs are in 3 dimensions, we can put in metrics like X number of feet for the clinician to a patient room, visualization within the surgery of certain amounts, you're able to see the screens around the room. We can put that data in. It'll start giving us a model to think about it. You still need a creative human to design it, but it gives you, some of the background for it. And I think where the opportunity lies is we can now start to tie anything that you can measure into the model. If it's measurable, it can be put into the model. So cost, return on investment, And I think what's really interesting, this is blue sky out there, but the work that's being done right now in behavior and neuroscience, positive psychology, what influences the way people make decisions, behavior, how can we put that kind of metric into a model that would influence the way we think about designing space? So I think that's sort of the blue sky out there.
Yeah, I want to turn to you, Clay. Your company's been able to identify some business opportunities in this sort of reimagination of the patient's journey, particularly, as I understand it, around post-acute care. Can you talk about some of the challenges in post-acute care and why they matter for patients and for the various stakeholders in the system?
Sure. So at naviHealth, our business is really focused on that portion of the patient journey called post-acute care, which in our experience is often overlooked, both from a cost standpoint, but also from a quality of care and the impact that has across the continuum. Just a couple of statistics, because I know it's late in the day and that maybe will help. For post-acute care, about 43% of all Medicare beneficiaries receive some form of post-acute care after a hospitalization. So whether that means going to a nursing home, whether that means going to inpatient rehab, whether that means going home and receiving home health, or managing transitions that oftentimes result in readmission. So it's a big number of our beneficiaries are receiving this care. The other couple other statistics I just referenced is the size of the problem. Post-acute costs have grown significantly over the past decade, actually outpacing the rise in inpatient costs by about 127%, which most people, when they think about the problem from a cost standpoint, don't think about the inefficiencies as it relates to post-acute care. The Institute of Medicine released a report earlier this year really focused on the regional variation in healthcare spend, and found that if we could just reduce the variation in post-acute care, we could reduce 73% of the total variation across healthcare. And when they speak to unexplained variation, essentially what that is utilization that's not driving outcome. So at naviHealth, our business is really focused on how do we take technology, analytics, as well as a skilled clinical team to empower and engage the patient in post-acute care. And similar to Rishi's comments around data, how do we take functional data, how do we take diagnostic data, how do we take social data to really provide the patient, the family, and their care team the type of data they would use when they go out to buy a car. Because today, for a patient, when they're leaving the hospital, the absence of data in making the determinations of where you go, how long you should go, and what are some of the risk factors we should be prepared for, lead one to lower quality of outcomes, but two, much overutilization. So our model is very much one that looks at the current reimbursement system that I would say, probably starts from the outside looking in, looking at how are providers paid in the different silos, not necessarily how a patient encounters this episode of care. When an 86-year-old fractures their hip and they've got early stage CHF, when they're looking at the next 90 days, they're not thinking of, I'm going to the hospital, then I'm going to a skilled nursing facility, then I'm going home to receive therapy, and then I'm going to need outpatient therapy. They're thinking of what's my recovery over the next 90 days. Our business model is how do we take data and use that to develop a comprehensive care plan that informs the patient, the family, the physicians, the discharge planning team on where patients will get the best outcome. And this is all evidence-based data based on a dozen plus years in post-acute. Where will they get the best outcome? How long should they go? What type of therapy will they need? And then even within that, what provider will provide the best outcome based on whether they had hip replacement or whether they had a stroke. So it's really about how do we use more data, better data, to help patients, providers, and the families make better decisions. We then surround them with a team of clinicians, nurses, therapists, social workers to manage a lot of the issues that Rishi spoke to from a social standpoint, because a lot of the complications are not just medical, but it's the combination of medical and social issues.
So are these people that you surround, you just said you surround this 86-year-old patient who's hurt his or her hip or whatever.
Right.
are these employees of yours?
Yes, we typically will work with health plans, we'll work with hospital systems, we'll work with ACOs, and we'll use our technology, our analytics to develop care plans, and then in the hospital we'll have a naviHealth nurse essentially navigating or serving as a concierge for that patient as they look over the next 90-day period.
And so one would presume that that's a model that we could hope to approximate in the wider
Yeah, today we're
system.
doing it with about 1.5 million Medicare Advantage members. Really what we're interested in and excited about is getting access to the broader fee-for-service population, which today is still 73% of all Medicare beneficiaries.
Yeah. Great. So we can take some Q&A. Who has questions they'd like to ask the panelists here? There's one over here.
Hi, my name is Kristen. I work at a consulting firm in Cambridge. My question is for Dr. Manchanda. I think this idea of making patient care sort of more holistic and looking at the outside environment is very important. It's almost Dr. House, right? How do you do it affordably? How do you do it without taking too much time, without losing the nuance, but still getting that outside care and making it too expensive for the user? I mean, you said you were in South Central LA. I'm guessing your patients were not necessarily the most wealthy. How do you make it so that they can afford it? Because that's not necessarily something that insurance covers right now.
It's a great question. I think I might flip the context a little bit and say, how can we not afford to do it? Yeah. So we know, for instance, like the patients that Clay was talking about and that I think has been discussed earlier, the high utilizers, right? We know that these 5% account for 50% of the spending, et cetera. And necessarily a lot of the solutions that make sense are the ones that wrap around care with medical and social and psychiatric, behavioral health, et cetera. That makes a lot of sense. I actually view that not only as a necessary kind of starting point to make an inroad here about the upstream kind of orientation that we require, but I view that data actually as a symptom of the fact that we're missing earlier opportunities for better treatment. So to close the story about Veronica, not only did I diagnose her, which is something that she hadn't had in the 3 years prior, with a high degree of confidence that she had chronic allergies and migraine headaches, but I was also able to then provide treatment, and the treatment wasn't just symptomatic relief, but it was also, by the way, here's the program, the community that's going to come and visit you in your home to make sure that we mitigate the risks that we've identified there after ruling out some of the other social potential contributors. She came in 3 months later, and we asked her to come in because it was a FQHC fee for service, so we, please come back in. She came back in, and she had not visited emergency rooms or any other care provider, and she was feeling better, and not coincidentally, her housing was better. The conditions were still there to a certain extent, but gotten a lot better because of the wraparound care that we linked her to, and we did it with the same kind of rigor and the same expectation that we would expect if she had a heart issue, right, to link to the cardiologist. So think about her story and think about the fact that we have, 16 cents of every dollar, I think, and I think IMS here, that one of the sponsors, has produced some literature about this. 16 cents of every dollar is spent on Medicaid. The vast majority of patients in the federal program right now are under Medicaid, 60 million or so, with more coming compared to Medicare. And I think right now the question is, as Medicaid expands, those are people who have disproportionate levels of social need. And they're coming into a system that is using, these are round pegs coming into square holes, right? We're not ready for them right now. And one of the things that's interesting, I like to quote Bob Marley a little bit, I did it a little earlier. In the abundance of water, the fool is thirsty, right? We have, Rat Race, good reference for a great song. We have an abundance of social data that's sitting there, and the systems that are actually really utilizing that social data and environmental data as well, to Joan's point, are the ones that are actually giving us glimpses of that better standard of care, because that's what that is. And by not doing so, the question is, how can we afford not to? And it turns out, we're already paying the price. We've been paying the price for a long time. The macro forces have lined up now to provide some opportunities to align payers, providers, and frankly, patients. This window is probably not going to last that long. The question is, how do we seize it from my perspective, how do we seize it for upstreamist work as well? Long answer, short question, sorry.
Other questions? So I had another question for you, Joan. You talked about some of the tools that you've used, and they sounded really modern and kind of exciting and slightly nerdy and sort of compelling in all these good ways. But they sounded expensive. We talked a little bit before about how the business you're in. I think people typically think the last thing we need to be doing is building more expensive facilities. So can you talk about how the facilities that you are, the projects you are working on are about ultimately providing greater value rather than, becoming, significantly more expensive amidst an already very quite, overburdened cost structure?
Right. So the tool I talked about, it's really quite a dumb tool and is very inexpensive. It's more about, garbage data in, garbage out, but good data in, good data out. So that's one thing. And I think, what we know is good design enables efficient, good, really effective care. It can reduce length of stay. It can really affect the way that you think about staffing and all that good stuff. It enables people to be able to perform at their best and to get well. And it's really that line of when do you invest and when don't you? I mean, we're seeing across the country a lot of institutions have held back, not knowing what's going on. Their infrastructure is decaying around them. It's costing like 3 times as much to run an OR because of whatever they need within something that was designed 40 years ago versus something now. So what we have to really get back to is bringing high value for that investment, making sure there's a return on that that's going to prove down the road.